सर अब हम लोग आज के मेन टॉपिक की तरफ आते हैं। आमिर बिरानी साहब से इस्तीफ़ा हासिल करने के लिए आज हम लोग यहाँ जमा हुए हैं। और अमीन सर, मैं आपको एक बात ख़ास तौर से बोलना चाह रहा हूँ कि हम जैसे कल स्टूडेंट थे आपके, आज भी हम लोग स्टूडेंट महसूस कर रहे हैं। वी आर नॉट डॉक्टर्स, वी आर स्टूडेंट ऑफ डॉक्टर अमीन बिरानी। तो आई विल कॉल हिम। हाँ, मुझे याद है वो कॉलेज के सुनहरे दिन, वो अभी तक ऐसा लगता है कि कल ही गुजरे हैं। मैं एक रिक्वेस्ट, एक या दो रिक्वेस्ट ऐसी करना चाहता हूँ कि प्लीज़ कीप योर मोबाइल ऑफ, सर के रेस्पेक्ट में भी और ज़्यादा से ज़्यादा फ़ायदा उठाने के लिए भी। और दूसरी बात, अपने से हम लोग डॉक्टर्स हैं, ये प्रोग्राम का लाइव यूट्यूब चल रहा है, तो ऐसी कोई हरकत हमसे नहीं सरदर्द हो जाए जहाँ पर कोई मतलब बिलो डिग्निटी हो जाए डॉक्टरों के। आई विल कॉल डॉक्टर बिरानी, प्लीज़ कम एंड फीड अप आवर माइंड ब्रेन सर। टॉपिक tuberculosis.
Assalamu alaikum. First of all, I would like to thank Dr. Asrar and Dr. Javed Shahjahan for kind words which they spoke about me. मेरा रिश्ता, जैसे डॉक्टर असरार ने बताया, भिवंडी से करीब 40 साल का है और मेरी पहली रिस्क जो अल्लाह ने मुझे दी है वो भिवंडी के अंदर दी है। क्योंकि जब मैं निकला 2 दिन के बाद तो असरार साहब ने मेरे हाथ में एक एनवलप दे दिया। मैं बोला चलो अल्हम्दुलिल्लाह, अल्लाह ने कमाई शुरू कर दी। दूसरी बात यह है कि मैं करीब 7 से 8 साल तक यहाँ आते रहा। स्टार्टिंग में हफ्ते में 3 बार आता था, फिर 2 बार आया, फिर 1 बार आया। और एज अ सेल्फिश पर्सन मैंने आई बिकेम टू बिजी, मैंने भिवंडी छोड़ दिया। लेकिन अल्लाह का एक करम है कि भिवंडी ने मुझे नहीं छोड़ा। आज भी हर हफ्ते मैं 1 या 2 मेरे पेशेंट जो आते हैं भिवंडी से आते हैं। और मेरे बच्चों को मैं बोलता हूँ कि देख बेटा, ये लगा हुआ है, जो मेरे नॉलेज से भी नहीं मिला है, मेरी मेडिसिन से भी नहीं मिला है। ये अल्लाह की मेहरबानी है कि लोग को इतना हमारे लिए प्यार है, मोहब्बत है, और इतने अच्छे अच्छे डॉक्टर हैं, इतने अच्छे अस्पताल हैं, फिर भी लोग आते हैं। तो मैं आप सबका शुक्रिया अदा करता हूँ। सबसे पहला शुक्रिया अल्लाह का, अल्हम्दुलिल्लाह। और आप सबका शुक्रिया कि जैसा आपने प्यार मुझे पहले दिया और आज मैं देखता हूँ आफ्टर 4-5 ईयर्स आई एम कमिंग हियर, वही प्यार आपकी आंखों में, आपकी ज़बान में और आपके बिहेवियर में। थैंक यू वेरी मच। आज का जो टॉपिक विच आई एम गोइंग टू टॉक अबाउट इज ट्यूबरकुलोसिस। दिस इज नॉट अ सिंपल टॉपिक, इट इज़ अ टॉपिक which all of us should know, and why we should know, I'll just start with my lecture with that. All over the world, about 9 million patients every year suffer from the tuberculosis. And out of that, 2 million people die every year. In that, the highest incidence of tuberculosis today in the world is in India. Every minute, a death occurs in India because of tuberculosis. And fortunately or unfortunately, one thing one has to remember, that is a preventable disease and curable disease. And in spite of that, people are dying. In the modern days, when there are so many good treatment for bypass, heart problems, neurology problem, infectious disease is yet killing people all over the world, and the maximum in India, which is a totally preventable disease and curable disease. This is the one disease which leaves no person, whichever community belongs to, whichever religion he belongs to, whichever country he belongs to. Anyone and everyone is likely to get tuberculosis if he is exposed to the person who is suffering from tuberculosis. But who are at the highest risk? The highest risk of getting tuberculosis is the people who are in the family. If you are exposed to the person who is suffering from pulmonary tuberculosis, if he is staying close to you for a longer time with you, there are chances that you will acquire the disease. It is not confined to family. Then it can spread in the school, it can spread in college, it can spread in the working which you are doing it. And it can spread to the person who are exposed to it most are doctors. So there was a study which was done in TB Siviri Hospital, which all of us are knowing about it, where they had seen from 2000 to 2015, there were at least every year about 10 to 12 healthcare worker. In them the number highest was a doctor who suffered from the tuberculosis. And what type of tuberculosis they had? Multiple drug resistant tuberculosis, about which I will be speaking later on. The disease which can kill, disease which requires 2 years therapy, disease which requires kanamycin for 6 months taking injection 6 months is actually very difficult. Default you, and then you spread this disease to your family member. You spread this disease to community. You spread disease to society. And that's the reason, as a doctor, it is our duty that, every patient of tuberculosis I see, I make it a point that I will diagnose this disease rightly. I will investigate this disease rightly, and I will treat this disease very rightly. If I do this, then inshallah we will be able to bring down the incidence of tuberculosis in our community maximum. Actually, being a Muslim, I have a patient which are mainly Muslim. Of course, I get non-Muslim patients also, and they are equally actually faithful to me, very appreciating to me also. But because of this, I am getting more patients. And you believe me, every year I am seeing more and more cases of tuberculosis from all over the India. They come from any part and they are suffering tuberculosis. And the tuberculosis which they are suffering is actually called MDR TB and XDR TB, which is very difficult to treat, which we will be discussing later on. So let's start how the journey of tuberculosis begins. It starts with the exposure. Exposure to the person who is suffering from the pulmonary tuberculosis and is having active tuberculosis in his lung. Now this person, when he starts coughing, what can happen? There can be infection or disease. Now remember, infection is different from the disease, which we will be discussing now. Everyone who is exposed to this aerosol, which is containing mycobacterium, are not getting infected. And everyone who is infected who do not get disease. So we should know what is infection and what is disease and how to approach it. Can you see this slide very clearly? Yeah. So here you can see a person who is having pulmonary coughs. You can see my arrow? Yeah. She is suffering from an open coughs or smear positive coughs or tuberculosis which can be spread to other people. When she starts coughing, speaking, laughing, singing, she throws, this mycobacteria and the droplets. Okay? Actually, whenever I am talking, there are droplets which are coming up which are not able to see it. And if it is inhaled by a person who is close to her and susceptible, that droplet will go in his mouth, and from there it will travel in the trachea and it will ultimately come to the lung. Once it comes to the lung, right, now this is the exposure. When it comes to lung, initially it goes into a lower lobe or middle lobe and it settles down there. And Allah has given us the immunity system. He doesn't want us to suffer. So the immunological system start working. So first thing what happens, there are protective cells which are called macrophage. They come and surround this mycobacteria. They don't allow them to grow further. They actually try to control them. And in about 70% of the people, about 95% of people, they will control the infection in the lung. So this person who has got this, he is infected, but he is not diseased. And this is called latent tuberculosis. This we have to understand, because at the end of the day we can treat different patients with a different type of tuberculosis. Now in this patient, those who are actually contented, 90 to 95% chance is there that they may not get tuberculosis in the future. 5% of them who has a low immunity, extreme of age, children who are small, they don't have good immunity. People who are old like us, they do not have good immunity. People who are suffering from HIV diseases. People who are taking steroid for pretty long time. People who have undergone transplant. Okay, these are people immunosuppressed. In that case, what happens? Because immunity is low, this AFB gets chance again to revive. Okay, they come back and they start destroying the lung. So now exposure, infection, and this is the disease. And the disease is the one when they come to you and me. When there is a primary tuberculosis, which is latent tuberculosis, so person's immunity goes down and activation of the multiplication of microbacteria starts and the destruction of lungs starts. And that is called, active disease. And this is called primary pulmonary progressive disease when it is actually within 2 years. So 5% will get activity within first 2 years and remaining can get after 2 years any time of the life. So if you go through this, exposure occurs, 30% get infected, no infection in 70%. Initially only they cough it out, no infection occurs in that. Those who are actually infected, 95% will not have any problem. 5% will progress initially and get a progressive primary tuberculosis. and remaining 5% will get late. So this much at least we should know. Infection is not a disease, and disease is the one which is symptomatic. Disease is the one which will spread to the other people, and disease is the one which has to be treated very vigorously. So latent tuberculosis, as I said, is actually latent or infection, and TB disease is different thing. There are no symptoms in latent tuberculosis, there are symptoms in TB disease. All investigation will be positive in your TB disease, sputum, everything, X-ray, everything may come normal there. They are not infectious, while these TB diseases are infectious. Okay? So this is one difference you should remember, what is infection and what is actually disease, so that you can treat patient accordingly. Now further, pulmonary tuberculosis is classified into two parts. One is called pulmonary tuberculosis and other is called extrapulmonary tuberculosis. Pulmonary tuberculosis is confined to lung parenchyma. Anything outside the lung parenchyma is extrapulmonary tuberculosis. And the pulmonary tuberculosis only which can spread infection to other people. Anything outside the lung will not spread. It will remain in the body. It will destroy the organ. It may kill the person. But it will be not spreading disease to anyone outside it. That much you should remember. About 70 to 80% of the cases which we see in our clinic are actually pulmonary, and about 10 to 40% are extrapulmonary. So which part of the TB, which part of the body can affect it? Right from scalp to the toe, and right from the skin, not only bone marrow, even bone marrow can get involved in it. No system of the body, no organ of the body, no part of the body is immune to the tuberculosis. When it happens in the lung parenchyma, it is actually primary tuberculosis. Anything outside, pleura, lymphatic system, central nervous system, genitourinary system, bone, joints, disseminated miliary tuberculosis, GI and skin, these are all called extrapulmonary tuberculosis. If you find that where I am not very clear, please stop and ask me question in between. I don't mind it. Okay, we can have interactive session also, which we'll be having later on. So now a person has come to me, and how I should approach a case of tuberculosis, that was the title of my topic, or today's topic title was that only. First thing, think or suspect tuberculosis. Second thing, test for the tuberculosis. Third thing, confirm the tuberculosis. And then last comes the treatment. And this cannot be done in one examination. You can see there are 4 steps. If you take these 4 steps, there are all chances that you will not miss the diagnosis or not overdiagnose it. Tuberculosis is a long-term therapy. If you don't treat in the right time, patient dies and family suffers. If you treat the patient who doesn't need, then he is spending money and there are side effects of the drug and he can have a complication because of the drug. It's very important to diagnose, confirm, and then think of treatment. And it has to be done as soon as possible. It has been found in pulmonary tuberculosis, before a person is started treatment after diagnosis, and when he becomes non-infectious, which takes about 2 months, he infects at least 15 people more. Okay? So you have a time limit and you have to do it properly. There are 2 types of symptomatic presentation in tuberculosis. One which is constitutional, which are common in whichever system is involved, whether it is a lung, whether the pleura, whether the GI tract, brain. They are actually people, we all know that fever, usually evening rise of fever, drenching perspiration at night, loss of appetite, okay, anorexia, weakness, and weight loss. These are in all the tuberculosis. But then every systemic tuberculosis having its own features or own symptoms. Okay? The investigation which we use in tuberculosis, one is imaging, and the most common is all of us are using is X-ray. But then there are other imaging, sonography, which are helpful in abdominal tuberculosis, in subpulmonary little effusion. CT scan actually is useful again, your abdominal tuberculosis and in the CNS tuberculosis. Same way MRI is good for skeletal tuberculosis. So I should know which will be the right investigation for my patient, so that I don't waste their money and waste my time. Okay? Other thing is pathology. Once you find tuberculosis, people do tissue histopathology, and then there is a microbiology of a fluid. Suppose ascitic fluid is there, pleural fluid is there, which we will be discussing now. And don't start the TB treatment unless you are confirmed. These are actually presumptive diagnosis. This will not confirm the diagnosis. Okay? So this all investigation, imaging is there, fluid examination is there, okay, histopathology is there. They are presumptive, most likely tuberculosis. Okay? But the definite diagnosis comes only for microbiology. for God's sake, don't start anti-TB drug without doing microbiology. And in that, there are 3 headings should come. If patient cannot afford, fortunately, one of the best program which I have seen of our government is actually a tuberculosis detection program, at least in Mumbai. Okay, actually I'm staying as I did have experience. Okay, my patients I cannot afford, then I said you go to JJ Nair, they have this special sale for it, where they will do this all tests free of charge. Otherwise they are costing in thousands. Don't start treatment. Don't start treatment unless you are doing this test. Why? We'll be coming to it. Karke, okay? So, pulmonary tuberculosis, as I said, is the most common. 80% of people have pulmonary tuberculosis. Not only common, it is the one tuberculosis which will be spread to other people. Okay? The symptom, beside that constitutional symptom which we described, there are symptoms of respiratory system. That will be cough, right? There will be hemoptysis. Okay? If it is near pleura, it can give pleuritic pain. It can behave like a pneumonia. These are additional symptoms of pulmonary tuberculosis beside constitutional symptom which I told you. Karke. Now, can anyone will tell me what is in this X-ray? Very right. Very right. Yeah, good. Sorry. Yeah. Dr. Salam Patel. Yeah. He is attending my lecture for last 30 years. And today when I told you that I am going to Bhiwandi, he said I am coming there also. Thank you, Salam Patel. And this is then, he knows my slides and he knows what will be the next I will be showing. Okay. So he said it is a cavity which is in the right apex. Secondary tuberculosis will always be in the right apex most of the time, unless there are immunosuppressed patients which will be having middle lobe. While the primary tuberculosis usually you will see in the lower part of the lobe, Ghon syndrome, Ghon lesion they call. We will not go in that detail. Can you see the cavity? The people who are having cavity are the most infectious. They are the most infectious people, and that's the reason you have to rapidly diagnose and rapidly treat this person. Yeah, anyone else besides Salam Patel would like to see this X-ray? Make any comments? Can you see my arrow? Okay, these are called right mid-zone infiltration. Yeah, Dr. Wright. I'm sorry, I forgot your name. What's your name, sir? Yeah, fine. So, right mid-zone. This can happen in the people who are immunosuppressed. In diabetic patient, HIV patient, you can get mid-zone infiltration. This is also tuberculosis, right? Oh, this is the worst part of the tuberculosis. Yeah, you can see there is a big pneumonia, infiltration and breaking down. Ultimate, this breaking down will become cavity which you saw on the first X-ray. Very advanced. You can see the complete left lung is involved. Right lung is compensating it by hyperinflation. That's why it's looking all black. All black. Right? Now in this patient, beside X-ray, the most important investigation is not CT scan. Your microbiology. Microbiology. Okay? Which I am repeating again and again. Gene expert, TB, MGIT, and last thing is AFB. Right? So you require sputum. It has been an experience of mine in 40 years when I talk to my pathology colleague, बोले 50% जो sputum आता है वो saliva रहता है. And disease is not in your mouth, it is in the lung. So it is my duty to tell भाई तुमको जो बलगम निकलता है अंदर से जो खकार निकलता है मराठी पेशंट का तुमची थुकी मला नाही नको पाहिजे बेडका जे निकलते हैं ते मला पाहिजे करून तुम पैसा मुँह से तो सलाइवा देगा थूकी देगा तो तुम्हारा पैसा वेस्ट होएगा हमको मालूम नहीं पड़ेगा तो आप बेहतर है सो दिस इज द थिंग एक्चुअली इट इज माय ड्यूटी योर ड्यूटी एंड एवरीवन ड्यूटी टू टेल देम व्हाट दे शुड गिव इट एंड व्हाट दे रिपोर्ट AFB not seen but it was saliva you don't see AFB so now I tell my pathology when I was working at least Prince Ali Khan and now Saifi that if you see saliva please write that it is the wrong sample it is saliva it is not sputum that I write AFB not seen I forget about TB. It's very important for all of us to see that they give sputum and tell our pathology friend, but if you see, you can see because they have given wrong sample. Write down it is saliva, not the right sample, so we don't ignore the TB. How many sputum should be given? Okay, very good. 3 samples that will be given. Okay, why? You can see this slide, very good. She is my old resident. I am so happy to see my student all around. Huh? तुमको कुछ क्वेश्चन पूछा मैं यार. So coming to this, you can see that when there is one sample, 80% chance of yield, you can get it. When there are 3 sample, 100% chance that you will be able to pick up the smear AFB. This pen is disturbing you, I am actually okay. Yeah. Okay, so beside anyone from this side, what is this X-ray showing? Yeah, yeah. So we have very good. I like the audience which talks to me also, and I also talk to them. Interactive session. So there is a right pleural effusion. It's a massive pleural effusion. Okay. Actually, all your full lung actually is occupied by the fluid. How you can say this is fluid? Because you can't see the right wall of the heart, you can't see the diaphragm. And it is pushing, mediastinum, left side, heart is gone, left upper is gone side. So this is a extra pulmonary tuberculosis, though it is in the chest, but it is not pulmonary. It will not infect anyone. But of course, he will require investigation, he will require treatment. Okay? So which will be the definitive investigation in this case? What you will do? Yes, you should do pleural tapping, and you will send pleural fluid for routine examination, ADA, right? Then you will send for cytology. Always, whenever you send us pleural fluid in elderly people, there are chances it may be malignancy. And this certain pleural effusion can be tubercle, it can be malignancy, it can be empyema, it can be chylus. So unless you have microbiology, you cannot say this is actually definite tuberculosis, right? Can you hear me, na? Yeah, fine. So you ask for gene expert, MGIT, culture, cytology, biochemistry. Usually you get exudate, we will not go in detail about it, and if you get ADA which is very high, it is suggestive, but final diagnosis will be on MGIT, gene expert and AFP. Okay, this is a young boy who came to the casualty of Prince Ali Khan Hospital with acute pain in the chest, with sudden breathlessness. He was acutely breathless, okay? So what is the diagnosis? Yeah, it is right-sided pneumothorax, very good, right-sided pneumothorax. What you will do in this case immediately? Okay, forget about investigation, save his life. Okay, so what you have to do? Put intercostal tube. You can see this lung is actually totally expanded. Now you start thinking of tuberculosis. Okay, so these are the manifestation of tuberculosis inside the chest, which are pulmonary and extrapulmonary, which we discussed. So you can get a pulmonary parenchymal infiltration, cavities, pneumonias. Outside you get near, your pleural effusion, pneumothorax, hydropneumothorax. Okay. Okay, what is this? Yeah, this is the cold abscess, right? So this is the patient. Why it is cold? Because abscess is very painful. But tubercle abscess is cold. It is looking great. But she said, I am not getting any pain. Okay, think of tuberculosis in this case. If you do not treat it in this time, it will rupture. And what is rupture? What happens? There is a sinus which is formed, okay, which will go on oozing. And the surrounding skin will become sclerosed, what is called scrofuloderma. Now, extrapyramidal TB, the most common tuberculosis is a lymphadenitis. And it happens usually in the upper part. Any part of lymph node can get upper part, supraclavicular node, cervical node are the one which get involved much, right? Initially you get single node which is enlarged, then you get two nodes which get mated, and then ultimately if you don't treat, it becomes abscess and then it ruptures. Now whenever you see this thing, the first thing which you should do is a biopsy. And in biopsy again histopathology which is presumptive, and the microbiology which is confirmatory. Now when you are doing biopsy, it has to be done by a person who is experienced in seeing this node. Actually I palpate my node, I can think of tuberculosis if mated, but I cannot be sure. But when they see with sonography, when they see with your transducer, they said this is abnormal node. Then I said that from the abnormal node you take the biopsy. If they take from the normal, money is wasted. Okay, so this has to be done by a person who is very, very experienced, and he should do the aspiration. Two things he has to do. If it is a abscess, send the pus, and if there is a solid tissue, send the tissue for histopathology and microbiology which I described. Okay, and it is usually painless swelling. Another thing, when you are sending for histopathology, please send in formalin. You are not getting it much, and always microbiology should be in saline. If you send in formalin, it's wasted. It will not grow anything. Okay, yeah, what is this? Okay, I'll give you a hint. What is this? Yeah, this is a port spine. You can see a good vertebra, and collapsed vertebra. Again collapsed vertebra. Good intervertebral disc, no disc, gone. Okay. So as I said, TB affects every system, scalp to the toe, skin to the bone marrow. So this is a skeletal tuberculosis. Okay. Which is better seen with MRI. Okay, skeletal tuberculosis. Again, you can see this. There is a good vertebra, diseased vertebra, intervertebral disc is gone. Good intervertebral disc, okay, lower down, all good vertebrae are there. So again, there is a tuberculosis which is here in between two vertebrae. Okay. Same thing in a different view. What is this? Okay. So when I became examiner, or when I went for the examination, my sir said, to me, if the best way of failing a student, okay, is show him normal X-ray. Okay, always you will try to find out the disease. This is perfectly normal X-ray. You can see good head of the femur. You can see good acetylum. You can see the good density of the head of the femur. And what happens to this? Head is gone. Can you see that? Okay, acetylum is actually destroyed. And there is a rarification, which you can see in the bone. This is the tuberculosis of the hip. Okay, so skeletal tuberculosis affects the weight-bearing joint. And in that, the most common is your vertebral column, then comes the hip, and then comes your knee. Remember that. These are the way it goes. But anything, even I have seen the dactylitis, tuberculosis of the, you must have seen, those who work in the NAR and everything, you have also seen that. Here again, patient will say, you start TB treatment. Dikta to hai tum bolte. Bola, nothing doing. I will go for, if there is a paraspinal abscess in the vertebra, then I aspirate the abscess. If I don't get, then I say, do the bone biopsy. Costly investigation, but at the right time I will pick up drug susceptible TB, MDR TB and XDR TB, which we will be discussing now. Don't start treatment on the basis of imaging, whether it is MRI, CT or your simple X-ray chest. X-ray is now no more used, because by this time already patient must have got a paraplegia. Such a collapse, paraplegia will occur. MRI has become very first investigation. Usually patient has lots of pain in the back, stiffness is there. Only thing, there is a localized tenderness. If you get localized tenderness with systemic or symptom which I told you, fever and everything, weight loss, exposed to the family member, by chance you see a cox in the chest, always do MRI. Okay? Because cox in the chest is treated differently than the cox in the spine, which will be again coming. All tuberculosis are not same. Okay? Everyone is not 4 drug, which I was told, by that, सबको मालूम है 4 drug देने का. बोला 4 drug अभी नहीं रह गया है. वो जमाना खत्म हो गया है. अब there are 13 drugs है. If you don't give right drug, you are in trouble and your patient is gone. Okay? So you have to prove that there is a skeletal tuberculosis, there is a pulmonary tuberculosis, there is a lymphadenitis, because treatment is different in different cases. Okay? So this is TB hip. Okay? Anyone? नाका नहीं चल रहा है क्या? अरे भाई कौन है इधर? Anyway, you can see it, na? Yeah, it doesn't matter. Yeah, you can see. Anyone? Okay, what is this? MRI of the brain, right? You can see these areas. These are called cystic changes. And it's better seen in this. Can you see multiple cystic changes? These are tuberculoma of the brain. So brain is involved by 2 ways. One is meningitis and parenchyma is tuberculoma of brain. Both of them are life-threatening TB. There are 2 TB which are called serious TB or life-threatening. Number 1 is actually TB meningitis and tuberculoma. More meningitis than tuberculoma, because tuberculoma will give you time. Meningitis will not give you time. And second thing, actually miliary tuberculosis. These are the 2 you have to be very careful and you have to start immediately. Okay? Again, if it is meningitis, don't start treatment on the basis of only X-ray or CT or MRI. You have to do CSF examination. Again, same, everything should be done routine. It will show exudate. Again, you have to send for microbiology, prove it and do it. In tuberculoma of the brain, okay, you have to do biopsy, stereotactic, which are not doing very commonly. Now also, even actually in the past also, we had tried here and there, very costly affair, tried KM, nothing was done. So we start empirically, in this case, one case, AKT without doing biopsy of the brain. Okay? Yeah, anyone, this is the investigation which has been given up long back. This is called small bowel enema, when there was no CT scan available. Now they do abdominal examination only by CT scan. No one does barium, which I was doing, Hafiz and everyone was doing it in the past. There is a stricture Okay, here, can you see the stricture? My arrow is in there, na? Yeah, stricture is there, and there is a dilatation, post stricture. This is ileocecal cox. Okay, so we saw skeletal, we saw the brain, we saw the lung and pleura, and now it comes to the abdomen. Abdomen, there can be a intestinal tuberculosis. There can be peritoneal tuberculosis. There can be tuberculosis of the node, abdominal node, and there can be tuberculosis of spleen and the liver. Okay, and then comes genitourine, which will be coming later on. So you can see that when there is a GI tuberculosis, it's not only intestinal. Everything requires different type of investigation. Suppose there is a colonic, which actually in this case, then you will do colonoscopy, do the histopathology and microbiology. Suppose it is a ascites. Okay, so now I don't have to do colonoscopy. What I am supposed to do, actually this is the ascitic fluid, right? You pass the needle, okay, and aspirate and send again for your biochemistry and microbiology. Okay, and suppose it is node, there are two ways by which is approach, either sonographically if it is possible, otherwise CT scan guided. But you will not start treatment on the basis of only your CT scan. That's one is to remember. Why will be coming later on, okay? So this is gastrointestinal thing which has happened. Yeah, females are here. They practice gynec. Yeah, what is there? What is this investigation? Yeah, very right. Hysterosalpingography. Okay, what we are supposed to see? Two tubes which are coming out of it. Right, there is no tube. And left you can see the tube and there is a hydrosalpinx. This is blocked. One of the most common cause of infertility in country like ours, where the tubercle is very much prevalent, is this. Okay, so this is a tuberculosis of fallopian tube. It can be on a uterus, endometrium also can get involved. Do DNC and do histopathology and do the microbiology before starting treatment. Sometime when we can't come up, then they do laparoscopic visualization, and then they pick up, nodules which are actually tuberculomas, and then they send for investigation. Okay, yeah, this is very advanced TB of kidney, which is called beaded appearance, tasbih ke jaisa hai. Okay, which now we don't see. What it affects in genitourinary system, it affects the uterus, which I showed you, and it affects your kidney parenchyma, okay, kidney cheilitis, kidney ureter, okay, genitourinary ureter, and even the bladder. Okay, and bladder tuberculosis actually was typically called golf ball appearance. So when people who are experienced neurosurgeon, they will say that this looks like a tuberculosis. Again, you have to do biopsy, but kidney tuberculosis and ureteric tuberculosis and even bladder, you are supposed to send 3 samples of urine. 3 samples of urine in the morning in the right laboratory. Okay, and they will pick up 90% chance of your mycobacteria. 90% chance. In past we used to collect for 24 hours and we are not getting anything. But with this molecular test which has come now, okay, MGIT which has come, 90% chance are there. So don't start, don't be in hurry. I have a patient who are middle class, lower class, and few are very high class. Okay, I was not anytime very big people doctor karke. So there are people who say doctor paisa nahi hai. Then I know that KM hospital is there. Okay, JJ is there, Nair, which they are doing all these things. Okay, getting done at Hinduja. I tell them you go there. Okay, without that I will not start a treatment. Okay. Tubercle pericarditis is actually, they get typical pain in the chest, okay, with the breathing it aggravated, they get fever. If you do echocardiography, you see the collection of the fluid, you tape it and send it, okay. So direct microscopy is one of the oldest investigation which was done in tuberculosis, which we are doing as a ZN staining. Now it is last investigation to be done. It again in the prism tube. There are other AFB which are not tubercle, can look like that. But yet they are important because immediately within half an hour you get the result. Then they write 1+, 2+, 3+. More the plus, more the infectivity. More vigorous you should be to treat this patient and see that he does not spread disease to other by telling them how to prevent the spread. Which will be, if we get time, we'll talk. If you are tired, then you tell me in between, I'll stop because I was told that you take 8 hours lecture. Kaise bola tha? Yeah, Hafiz told me. I said, you just raise the hand, I'll stop. Huh? Okay, good. So gene expert tape which has come very recently in last few years, and is thanks to Bill Gates, okay, who introduced this test at a very subsidized rate in India. Okay, the first lecture about gene expert which I heard was actually sponsored by them. A person who was Indian, who was trained in Canada, he had come and I attended the lecture. And then he told that, doctors, your TB can be diagnosed with confirmation within 2 hours. And not only that, I can tell you that this TB is a drug susceptible TB or whether it is MDR TB. In 2 hours, I was surprised. बोला हम लोग को स्मेयर भेजते हैं तो 2 दिन के बाद रिपोर्ट आता है. Okay? And what is important? It does not require microscope. It does not require technician who is very much trained. Okay? It does not require stain. Okay? And now they have come out, with a gadget which actually does this test. It's a battery operated. You can do anywhere. Okay? That's the first time actually I attended and heard and learned about it. Okay? So this is actually a thing which gives you result in 2 hours. It comes up that there is a TB. It's a molecular test. Okay? And it will tell you that patient is rifampicin resistant. On the first day, that MDR is actually time bomb waiting to explode. Not for him, for everyone who is around him. And in that, we all are also there. We all are also there. Okay? So in these cases, actually, you get in 2 hours, actually by next day we get the report. Immediately you have to start doing more reports for your further drug resistance. Okay, which will be coming. So now gene expert actually is the one, within 2 hours you get the report, that there is a tuberculosis, that MDR. MDR actually by definition is rifampicin and isoniazid resistant. If 2 drugs are resistant, then it is MDR. It does not test isoniazid, but it has been found that those who are rifampicin resistant, 90% of them, okay, will be isoniazid resistant also. Okay? Then comes TB MGIT. I am sure all of you must be asking TB MGIT. Okay, TB MGIT is a culture. Again, it is a definitive diagnosis, but it takes 1 week to 3 weeks to 6 weeks to grow the bug. Okay, but when I was student at Nair Hospital, we had this is called liquid. What do you want? Liquid culture. Culture is actually in liquid. The other is the culture is the solid. We had actually LJ solid culture thing. It used to take 12 weeks. By the time report comes, patient has gone away. Okay? But this within 1 week, they will tell you that growth is there. And then you can ask for 13 drug test on it. We'll not go in detail. Today, the best place to send for MGIT is one place, and that is, your Hinduja Hospital. There are now good people everywhere around also, but it is, I always tell my patient, go to Hinduja. Okay? And after that, you have to do drug susceptibility test in the whatever its growth. That will tell you which drug are actually acting. That will identify drug susceptible TB, MDR TB and HDR TB. Okay? Okay, how many of you are doing now this test and how many of you have done this test? This is called Montu test. Now it is called TST. Another is IGRA. Karate हैं अभी आप लोग? Now, in pediatric patient, yet it is used. But otherwise, in one of my old lectures yesterday, there is most used, confused and abuse test. आया बड़ा दिखा AKT चालू कर दो, बाद में एक्सरे भी की जरूरत नहीं है करके. Thank you very much. एक्सरे की भी जरूरत नहीं. Okay. So this is the test which will detect only infection. It will not tell you that this is active disease or not. So on that basis, you can say the person is infected. People who are having disease will be having positive. People who are not having disease and having infection will be positive. So IGRA test is which is a blood test, which will not go in detail, very costly test. Both of them are actually same. They will tell you there is infection with or without disease. So if you waste your money on this, it will be of no use. But in pediatric, they have special thing on which will not go in detail because I am not a pediatrician. So don't waste money on that. On the basis of this, don't start the treatment. Sorry? That is quantifer and gold. Okay, you want to listen? That's fine. I thought you are tired. Now TST or Montu test actually tests what that person has been infected, but it cannot tell you that person is actually disease. But people like us, all of us, may have MT positive, though you are not having outside infection and you don't have disease. Why? Because all of us have been on BCG in childhood. All of us will see that there is scar of BCG that. Anyone has taken the BCG, TSC will come positive. We have been infected by BCG, which is part of tuberculosis, okay, but we do not have fortunately disease, right? It will be an active disease, whether it is here, it will not distinguish करके. So they came out with the IGRA test plus TSC, intradermal injection. How many of them know that what is intradermal injection? Very difficult to say. They don't know how to do. If they give subcutaneous, it will be waste. Then you are supposed to call them after 48 hours and 72 hours and read it. You are supposed to read, induration, not erythema. There are all chances of mistake, and half the people will not go after 48 hours, 72 hours, they will go after 2, 3, 4, 5 days, and it is all wasted. So they came, and two things are there. BCG will show a false report, and this is not properly seen, unnecessarily diagnosed tuberculosis. So they came out, with IGRA, which is a blood test, okay, which also shows you that this patient is having infection or disease. Okay, in latent tuberculosis in the Western world, they use this test, quantiferon. One time you collect the blood, you get report without anyone getting in, seeing or whatever it is there. Okay, and it doesn't get affected by BCG. Okay, so that is now what you said. This name is quantiferon gold. Ideally, this is called IGRA. Okay. So, who can cure the tuberculosis? Okay, remember that time over there when people were diagnosed tuberculosis, what they were giving the treatment? Go to the Panchgani, go to the Mahabaleshwar, stay there, okay? You will get, it was not a wrong thing in the time when there was no medication available, okay? Many were dying, but nature, okay, improves your immunity. And for immunity, you require your good nature, good food, and it fights the disease. So many were surviving, so it became a part of treatment. And there were so many sanatorium in the America, okay, in the Western Europe, which were actually keeping TB patient there in a healthy atmosphere, okay. And in 1940 or 50, they destroyed all the sanatorium. So they said that we have actually won our war against tuberculosis. There were no tuberculosis in America. No tuberculosis, or very less. They said we always import tuberculosis rather than having tuberculosis of our own. What are import? People like us, Indian, Pakistani, Bangladeshis, they go there, they take tuberculosis over there, and they are diagnosed tuberculosis. Otherwise, there was no tuberculosis. So they destroyed all the things. But one more thing they destroyed. The last drug, which was the most effective drug today also is rifampicin, was found in 1960. Okay? Why? They were yet facing the tuberculosis. The day they thought that now there is no use of investigating this type of a drug or investing in them, they stopped doing it. So after that, there was no more new drug till new drug which has come in now, bedaquiline in 2012. And why it happened? You can say thanks to the HIV. When HIV came, even American had immunosuppression, and they started getting this type of disease, and they started investigating tuberculosis more and more. So the best person is a healthcare person. Homeopathy, Unani, Ayurvedic, they does not have. And आजकल the hijama का जो trend चला है, I'm sorry to say that everyone thinks that anything and everything can be cured by hijama. Okay, that is not right thing. Okay. So when you start a TB treatment, now it is your role. How you can give a right thing so that patient is definitely cured, inshallah, as you say. Okay. There should be appropriate combination of the drugs. There should be appropriate doses of the drug. There should be appropriate duration of the drug and strict adherence. Okay, what comes DOT, direct observation therapy. अभी डॉट के लिए वहाँ जाता है, आज बस की हड़ताल हो गई, कल हुल्लड़ हो गया, मैं नहीं जा पाया. DOT is actually your family member, and the best family member who can look after you best is the women. Whether she is your wife, whether she is your mother, whether she is your daughter or your sister. All males are useless. They will not actually care for anything except doing work and making money. So always ask one of the family members that तुम देखो कि सवेरे दवा खाए. I said that एक दिन खाना नहीं खाएंगे तो first thing क्या क्या खिलाऊं, मैं कुछ खिला मत, खाली दवा खिला. दवा खिलाएंगे अच्छा हो जाएगा, तो रोज बादाम पिस्ता खिलाएंगे अच्छी नहीं होने वाला है. And then you give response to one of the women, that is DOT. Okay, you will give them in morning this. By chance they forget, give after breakfast. Don't stop any single drug. Okay. What is the appropriate combination? There are first kind of the therapy. Okay. So before going to that, let's see what are the different type of treatment for different type of tuberculosis. We saw pulmonary, extrapulmonary. We saw latent and active disease. And now there is third thing which is coming. That is called drug susceptible TB There is called multiple drug resistant TB, and then there is extensive drug resistant TB. And all three are having different type of treatment. For drug susceptible TB, the first 4 best drugs which are there, which I will be showing you, you can use them to treat them. If there is MDR TB, that is rifampicin and resistant to even isoniazid, that is MDR TB, don't touch this patient. Even I don't do it. In the past, I used to use kanamycin injection 6 months and 2 years therapy with second line of therapy. We'll be coming to that. Now the therapy has changed. No injection therapy, and which I'll be discussing with you. But that actually is available only in government hospital. Okay? At the time of the last thing, I'll be discussing with you that. And extensive actually is very bad. It is resistant to rifampicin, it is resistant to isoniazid, it is resistant to 2 other good drugs. One is quinolones, okay, fluoroquinolones, and initially it was aminoglycoside. If these 4 are there, it's a death certificate of the patient and problem for everyone surrounding him. Okay? So these are the first line of therapy which are to be used in your drug susceptible TB: isoniazid, rifampicin, pyritinamide, and ethambutol. These are the 4 drugs can be used in them. Okay? There is an intensive phase and there is a continuation phase. Intensive phase is for 2 months. You can see this slide, there are 4 drugs to be given. H is actually your isoniazid, R is your rifampicin, Z is your pyritinamide and ethambutol. And then it is followed by 3 drugs for 4 months HRE. Now this is simple, 4 and 3. That is actually appropriate combination. What is the second thing? Appropriate doses. And doses are calculated milligram per kilogram. If you go underdose, then you are going to cause MDR. If you go overdose, you are going to cause complication. If you are disturbed, then you can tell them to stop. I don't mind it. Okay. So this is very important. You don't have to now. Actually, I tell my all students that my library is in my pocket. I forget all this thing now. So I go to Google Dada and say, "Bhai, isoniazid ka dose batao." So this chart is there. See the weight, okay, and then calculate. Isoniazid 5 milligram per kilogram, maximum dose is 300 milligram. Okay, rifampicin 10 milligram per kilogram, maximum dose is 600 milligram. Pyritinamide 25 milligram per kilogram, maximum 2 gram. Okay, ethambutol 15 milligram per kilogram, maximum actually 1400 milligram. And there is a streptomycin which has now been removed from this list. Now streptomycin is no more primary drug because we have used it, abused it, and now it becomes useless drug. Okay. Now someone was asking me somewhere, yeah, Mr. Khalid from this healthcare. Okay, doctor. You asked me that question. Yeah. What was your question? You said, I'm seeing that, your prescription are little different than, what is prescribed by the municipal hospital. Okay. I said they are as much as right as I am. Okay. I am an old timer and I am used to, calculating in my brain rather than using my calculator. So I calculate faster, it becomes easier for me. And they have come out for the new generation which have to find out, their laptop and then, your computer and then see what is dose. So they believe in this chart. They open this in a minute, they see. So these are actually according to weight. Okay. If it is 16 to 20, this is actually printed. I am not going to read it. You go to Google and you will get it. So this you can keep under your and do it. नहीं क्वेरी नहीं, अब क्या है वो खाली तरह बंद कर दे। So tuberculosis is not a play of 4 drugs which I was told just now. कि 4 ड्रग में तो यूज करने का है. There is a pulmonary tuberculosis, there is MDR tuberculosis, XDR DST, and there is a pulmonary and extrapulmonary tuberculosis. Here the duration is different. Pulmonary, I said 6 months is good enough. If it is extrapulmonary, it is TB lymphadenitis. In Western book, you will read that 6 months is enough. Okay, but in actually India, people give up to 9 months. Okay, so depending upon the response, you may have to give up to 9 months also. When it is a joint TB, bone and joint TB, miliary TB, TB meningitis, treatment is for 12 months. You understand? If you follow a 6-month therapy here, you are going to cause a problem. There will be relapse and there will be MDR TB will be there. And for cerebral tuberculosis, 2 years. So appropriate combination, appropriate dose, and appropriate duration. And the last thing is the adherence, which actually I showed. Okay. Now one more thing has come on. Pregnancy is one of the most normal thing, okay, in the world. So in pregnant woman, can you give the same line of therapy? So for you and me, we should know that, you know, a person who is pregnant, okay, the therapy are 2 types. If you are in USA, they will not use pyrazinamide because they feel that it is teratogenic drug. If you don't use pyrazinamide, then you have to give rifampicin INH, okay, rifampicin INH in somewhere for 9 months. You get my point? They will not use it because they are worried medically, there are not enough paper. But now there is a guidelines which has come from the WHO. They said that, you know, you can use pyrazinamide in pregnant woman also. Now suppose this patient come to your clinic, what you would do? You will use pyrazinamide or not? You will use pyrazinamide or not? Huh? Catch 22 situation, na? Yeah, doctor, Hafiz, Mustaq, you will use pyrazinamide, pregnant woman ना ये बोलेंगे दो के नहीं दो करके. Advantage that in 6 months therapy is over. Disadvantage that 9 month therapy लेना पड़ेगा. Okay. So in this case, when they come to my clinic, what I do? I tell them there are 2 guidelines. Okay. It's WHO, which is as respected as, you know, your CDC. I would give you 4 drugs so that, you know, in 6 months it is over. Because more the time, more chance of defaulting. But if you say no, I'll give 3 drugs. Let, you know, it is a duty of doctor to give information. It is a right of patient to take the decision. Decision will be there, but they will take decision on the information which you will give. Okay. Now people come read and tell me, you know, कि मेरा WBC इतना बढ़ गया, प्लेटलेट कम हो गया, तो इसमें तो कौन सी डिजीज है बताओ, मैंने 4 पढ़ा है करके. Okay. So we have to educate ourselves every day, which actually I am doing now also at 72, right? Children and infant I will not talk because I am not a pediatrician. Okay. HIV and TB, when it comes, I call it a HIV, co-infection of HIV and your TB is a dual dance of death. If you don't treat in the right time, most of them will die. One of the most common cause of death in HIV patient in the past, when there was no treatment of art, they were dying of tuberculosis in our country. We will not go in detail about it. You will actually refer to the person who is expert in that, he will do it. Now as a family physician, a physician like me, I am also a family physician, what I should watch when I start, you know, giving AKT? Not 4 drugs. I should watch for the jaundice. Okay? If it is jaundice, then I know there are 3 drugs which are culprit for it. What are these 3? Yeah, rifampicin, isoniazid, pyrazinamide. Okay? If I continue all 3, patient will die of liver failure. Okay? If I remove all the 3, there will be long-term therapy, default, and all thing will happen. So then there is a method by which you can find out which drug should be omitted. Now that will not go in detail because I can say probably you are tired and I am also a little tired. But you should now refer, they stop drug and then introduce one karke. The most toxic actually is pyrazinamide. And usually after introducing one drug, pyrazinamide stop karke. Next one is isoniazid, lastly rifampicin. So what they introduce and then introduce rifampicin, isoniazid, there is no jaundice after 3 or 4, 5 weeks. Then they don't introduce pyrazinamide. They continue only your H, R and E, no pyrazinamide. And then what will happen? Now therapy will be for longer time. 1 drug you remove, 9 month therapy will be there. So it's not a play of 4 drugs. Okay? I am telling you the person who said 4 drugs mein kya maja aata hai karke. It is not, you have to think every time. Eye examination is mandatory in patient of tuberculosis. Why? Yeah, ethambutol toxicity. I have seen unfortunately patient losing the vision. It happens 1 in lakh, but I don't know which will be that one. First one or 1,000 one or 100,000 one. Okay? So you are supposed to tell them, okay, you are supposed to examine your eye every 2 months, okay, with visual acuity, color vision and fundus. And that's the reason ethambutol is contraindicated in the children who are below 8 years. Because adults will tell, actually there is a stamp which I put on my paper, कि आँख में देखने में तकलीफ होती है, immediately आके मुझे बोला आपकी दवा बंद करेंगे. It's very rare. but you are going to lose the vision. Okay, so otherwise every 2 months you are supposed to check the eye, visual acuity, color vision and fundus. Okay, arthralgia, where you get arthralgia, which drug? Very true, pyridinamide is the one which can cause arthralgia. It's not a contraindication, you don't have to stop it unless there is a gout attack. Give painkiller, finish 2 months, because there is another very good drug in the first line of therapy. Pruritus can happen with any and every drug. Okay, even B12 can cause, you can say, pruritus. Don't stop it. How bad it is it? Treat symptomatically, self-limiting, and use all the drug which you want to use it karke. Persistent numbness in hand and the feet. It is iron itch. To prevent that, what are we giving in this therapy? When we are using HRZD? Pyridoxine, yeah, pyridoxine. Huh? That is actually should be given. Some they give half, you give full tablet. There is no harm. Okay. MDR TB will not go in detail. Rifampicin, as you know, resistant. If I see MDR TB in my clinic about 2 years back, I was treating them with at least 6 drugs. Okay, and the default rate was very high. After 1 or 2 months, injection to be taken even say alternate day, every time. बटक या हाथ पे जगह नहीं है, all thin emaciated people, they will say डॉक्टर साहब कुछ भी हो जाएगा, मर जाएंगे, इंजेक्शन नहीं लेंगे हम. Then there is the ototoxicity and nephrotoxicity. In pregnant women you can't give it. Okay, so most of the time they used to default. Okay, other drug which we are using, which has now gone in the second line, which we will not be discussing, they are very toxic. The first line is why first line? Because they are the drug which are the most effective. Why they are first line? They are the drug which are very, very reasonably priced, very cost effective. They are the drug which are having minimum side effect, very rarely life-threatening effect. What is the problem with second line of drug? They have lots of toxicity. Okay, duration of drug is treatment is very long. Up to 2 years you have to give the treatment karke. Okay, and then patient defaults. XDR TB is worse than MDR. Okay, in MDR TB we used to use 2 extra drugs which are supposed to be very good. One was quinolone, another was your aminoglycoside, amikacin, kanamycin. But now, fortunately, something new has happened. This is the latest guideline which has come, all thanks to bedaquiline which has come in the market. Okay, what I was treating has become redundant, outdated as far as MDR TB is concerned. Now the first drug which are actually here are levofloxacin, moxifloxacin in MDR TB, that is actually quinolone. Second is bedaquiline, a magic drug like rifampicin in MDR TB, okay, in even XDR TB, and linezolid. These are the 3 drugs which are primary. And then there are a list of other drugs. Clofazimine, where were you using clofazimine? Where were you using? Any other disease you remember? Leprosy, yeah? Now it has come here. I think he is tired of my lecture, huh? The one who is controlling the fan. Okay, right. So clofazimine, actually, one thing you should tell when you give clofazimine, that your skin will become brown. Have you seen clofazimine side effect? No? Skin becomes totally brown. Totally brown. But fortunately, once you stop the clofazimine, it becomes normal. Anyone will be very conscious about it. बाहर जाएंगे तो बोले तेरा चमड़ी को क्या हो गया करके, right? So this is the group. Now when this patient come to me now, what I do? I tell them देखो तुम्हारे पास 4 choice है. या तो तुम जेजे में जाओ, या तुम नायर में जाओ, या तुम सायन में जाओ, या केएम में जाओ. वहाँ टीबी सेल चला हुआ है. या सिवरी हॉस्पिटल सिवरी टीबी में जाओ. When they go there, they are treated like a VIP. Only place, in municipal hospital, government hospital and CVTB. So these are the thing which has been taken for public-private combination. They have sponsored this program. I have heard that, Bill Gates also sponsored too much. They want, the doctor who are working there, they are paid very well. They do a thorough investigation. Okay? And after that thorough investigation, they decide this is MDR or XDR. These are the drug to be used, and then they will start the treatment on them. Okay? They will call them every 2 weeks. Okay, then they will call them every month. If you don't go, they will phone you, they will message you, and probably they may send you person also. That good, this program is there. So don't think that all municipal or teaching institute are bad. And then what happened? If they have taken treatment in JJ, my patient from Mumbai and Bhiwandi, I said, "Abhi yahan tum bole JJ aana bahut takleef hota hai." I said, "Go to JJ." They write, that some Shivaji hospital is there in Mumra, Kalwa, हाँ, वहाँ लिख के देता है उनको. कुछ खड़ा नहीं रहने का, बताने का पेपर, एवरी 15 दिन आओ दवा लेके जाओ करके. Bedaquiline is one of the costliest drug in market, and even if you are richest of rich, okay, Ambani Adani sponsors you, you cannot buy it because it is not available in the market. It is to be sold only by these hospitals, okay, or given by the hospital free of charge. So if you see MDR, XDR, like I was stopped touching with kanamycin, amikacin, I tell them go there, I will monitor you, I will guide you, okay, but this is the one treatment they will be giving it, okay. Treatment is for 18 months to 2 years, 24 months, okay. See, human desire to find something new for good of themselves and for the good of society never stops, okay. 2-year therapy, even with the oral tablet, there are all chances that you will miss the tablet, you may stop the tablet, okay. So they come out, now this is actually experimental therapy. In 6 months, they can cure MDR and XDR, okay. There are lots of if and buts are there, okay. Why it is good for the person who discovers it and why it's good for the people? Good for the person. If I invent something, why it's good for me? I will make lots of money. And there is nothing wrong in making money. Okay, you are putting your effort in that. You should make in money. Actually, मैं मौलाना ने सोचते देखो इस्लाम में कहीं नहीं लिखा कि इससे ज़्यादा मत कमाना और इस्लाम में ये भी नहीं लिखा कि इससे ज़्यादा मत खर्चा करना. बोला अच्छा मौलाना ऐसा है, हाँ लेकिन एक बात मेरी सुन लो. बोला क्या? बोलो मौलाना एक राइडर रखा है, इंग्लिश स्पीकिंग मौलाना. बोला क्या राइडर है? उसमें लिखा है कि हलाल से कमाना और हलाल से खर्चा करने का. तो तू कितना भी कमा और कितना भी खर्च, अब हलाल की लिमिट है तो अपने को मालूम है क्या करना है. तो बोले कि मदरसे कैसे चलेंगे, यतीम खाना कैसे चलेंगे, गरीब को तुम कैसे, यू हैव टू अर्न टू गिव द राइट थिंग करके, ओके. सो दिस इज व्हाट इट इज करके. नाउ दिस इज द थेरेपी विच इज दैट इन द एक्सपेरिमेंटल स्टेज. वी ऑल होप इंशाल्लाह इट कम्स बैक, then we can cure our patient within 6 months, okay. So thank you very much. Thank you to all of you and thank you to the person who shut the fan in the right time, okay. Any queries? Skin TB is actually same. If it is drug susceptible, it will be 6 months. There is no shortcut. Now, just for your information, can you see how many slides are there? There are 282 slides, and I have shown you only 50 slides. So it is not a 4 drugs magic, okay. I have selected only this much. Then there are postgraduate students, you have to approach them differently. There are MBBS students, you have to approach differently. So there are different slides for different people. But for me and you, family physician, at least if we can do this, I am sure we will be able to diagnose right TB and we will give them right treatment. Last thing, Dr. Asra was asking me what I can do for this patient karke. Something I want to do charity. Can you hear me? Yeah. So I said, when I go for a person for a donation, and I said, there is a cardiac program you want to start. People are willing to give me money immediately. When I go, there is a cancer का बहुत बड़ा हम लोग इंस्टीट्यूट चालू करते हैं. आप कुछ पैसा देंगे, वो दे देते हैं. And then actually I was running free TB clinic at Prince Ali Khan Hospital for 10 years. I am sure Hafid must be knowing about it करके. Okay. When I tell them कि मेरे को TB के पेशेंट के लिए पैसा कलेक्ट करना है, अच्छा डॉक्टर साहब बाद में अपन देखते करके. It puts them off because they don't know what it is doing to our society. Okay. So I was telling him, those people who are interested in charity, they should have one dedicated TB cell in Bhiwandi. Okay. Like you are in Therapeutic Diagnostic Center, and in that you should have the gene expert ready. Your Hinduja is able to give you subsidized rate if you have contact with them, and you appoint one good doctor and pay him well. लोग को समझता है कि डॉक्टर फ्री में काम करेगा, कम पैसे, काय के लिए कम पैसे काम करना, कितना साल लगता है उसको पढ़ने के लिए. पे हिम वेल एंड पे हिम नॉट फुल टाइम पे, गिव हिम पर पेशेंट. पर पेशेंट मतलब मेरे को मतलब नेक्स्ट पेशेंट आएगा तो अच्छा है, तो पहले पेशेंट को मेरे को अच्छा भी करना है, उससे अच्छी तरह बात भी करना है. मेक इट रिजनेबल बट गुड इनफ फॉर हिम टू कम टू भिवंडी एंड प्रैक्टिस. इफ यू डू दिस, आई एम श्योर यू विल बी डूइंग वन ऑफ द बेस्ट थिंग you can do for this our community and for our society and our Indian humanity. Think about it. Think about it. Because I can see when I talk about tuberculosis free, people get put off. It should not be there. This is the one disease, curable, preventable. We all should do it. Thank you very much.